Hello folks, my name's Shaun Speed. Let's just give a couple of minutes and then we'll get started on the chat. So. Thanks, Alex. Okay, I think we're good to go now. It's past. Okay, yeah, thank you for joining us. I'd actually prefer, as we're going along, if you want to ask questions, you put them into the chat box if you would, and then I'll discuss all of the questions at the end. I've timed this session so that we can go to about 15, 16 minutes, but sometimes I tend to speak a bit quickly. Okay, just let me tell you a little bit about myself. I'm an adult nurse. My name's Shaun Speed, and an adult nurse. When I was young, at age 16 and 17, I knew I wanted to be either a teacher, a priest, or a nurse, and being a nurse won. I was the first in my family. I've got 6 brothers to go to university or to do any professional education, and I've loved it ever since. So my background is I spent a lot of time working. I qualified as a nurse back in the early 80s and went to work in a big hospital in Liverpool where I worked in accident and emergency and intensive care. So I did about 5, 6 or 7 years there. And then I left there and went and did a degree full time and still work part time as a nurse in A&E and ITU. So I've had experience of working in the very acute sector. After I got my degree, one of the things I realised when I was working on A&E in particular, was that people who had substance problems or alcohol problems weren't necessarily given the best treatment when they came in because they were ill. And we'd see very often people coming in and going out and coming in and coming back, and the same faces would turn up again. So when I got to the end of my degree, I decided to think about changing my career, and I moved over to the Wirral, and I started work as a new service that had just begun for drug users and problem drinkers, which was based around helping them out with their physical health problems. For those of you that don't know, you might want to ask your parents. If your parents are about 40s or 50s, they'll remember in Liverpool and on the Wirral at the time, there's a really big increase in the amount of heroin that was being used by people. Lots of research being done since, and it was related to a number of factors, but the fact that Liverpool was really quite poor at the time, as was the Wirral, and it was just ripe for drug dealers to come in and start selling heroin, which they did very successfully. At the same time, there were 2 really famous doctors, Howard Seymour and John Ashton, from Liverpool, who set up a public health service, which was looking at tackling drug misuse with a harm reduction framework. And by a harm reduction framework, we just mean instead of treating drug users, we help them to protect themselves from further harm. The treatment that was available for drug services at that time was minimal. This is back in the 80s and 90s. And quite often what happened, if you went to your doctor and you said that you had a heroin problem, they'd send you off to see a psychiatrist, and the psychiatrist would give you 6 weeks of methadone, starting on a dose of around 40 mils, and by the end of the 6 weeks, you'd be finished. So what we found were that people were doing that 3 and 4 and 5 times a year, and they weren't getting off drugs. They were just going straight back to the communities that they came from. And what happened is they carried on taking drugs. The temptations were there for them. So Merseyside and Cheshire and Wirral, we developed a model called a harm reduction model. So that was to try and work with people to reduce the harm taking drugs was going to have on their health. And this was firstly set up through an organisation called the Merseyside Drug Training and Information Centre by a guy called Pat O'Hare, who's really quite famous in public health now. At the same time, towards the late 1980s, early 90s, HIV started to become more prevalent. And it was realised at that time that HIV had the potential to spread into the wider heterosexual population through substance misusers who were sharing needles and syringes. So the aim of our outreach, our work, the work that we did at that time in those early days, was to try and make contact with as many drug users as we possibly could, to try and maintain contact with them, to get them into healthcare services. And hopefully by doing that, we were hoping to make them change their behaviours. A big report that came out in the early 90s was a report called the ACMD, the Advisory Council on the Misuse of Drugs, which is based in research. And the basic premise there was that we realised that the spread of HIV is a greater threat to public health than drug misuse. So what they said there is the fact that HIV is likely to spread through this community and then on to other communities means that, in fact, there would be a big problem at some stage in the future in terms of public health. So we started to look at treatment services, and we developed on the Wirral with the aid of a guy called Dr. Stefan Yanukiewicz, a treatment service that wasn't really about just getting people off drugs straight away. We knew that we needed to maintain contact. We knew we needed to promote the health of people, and we knew we needed to keep them safe from HIV and other bloodborne viruses. So we started to prescribe them more long-term prescribing. So in the late 90s, early 90s to late 90s, it wasn't unusual for people to come into drug treatment and to be stabilised on their methadone rather than being brought off methadone. And I was very, very much a part of setting up those services. And I became actually the clinical manager of them for a while. Okay, let me just flip over so make sure I'm getting everything in. We initially set up a syringe exchange scheme on the Wirral, and that caused lots of problems, and we had to go to lots of communities and talk to them about what we were doing and what we were hoping to do. So that meant us involving service users and their families, and particularly an organisation on the Wirral called Parents Against Drug Abuse, who were very supportive of our approach to keeping people safe. What we were finding through Dr. Yanukiewicz's clinic and our own services was that people were turning up with really awful injection injuries from poor injection practice, with abscesses, with hepatitis B and later hepatitis C, with poor diet. They had really awful dentition. And then there were a number of women who were pregnant or planning pregnancies who were using drugs that were experiencing difficulties in getting help and support with their drug use. So the aim there, and really, if this is a public health framework, you know, I'm talking to you a bit about alternative roles for nurses, and our aim was to make contact with drug users, and we did that through outreach work, outreach strategies. These were all evidence-based, and we researched them as we went along. We wanted to maintain contact with people, so we had a key worker system, so people who use substances would have one key worker. And we wanted to help people make change, and we just realised that those changes would take a long time. So, you know, we didn't have a definite time that people would be in treatment. We negotiated reductions slowly over prolonged periods of times. Okay. At the time I became the clinical manager, we had made contact very quickly with around about 3,500 or 4,000 injecting drug users and their partners and families. So we had a massive population of drug users. And Wirral itself, our services and Liverpool services, had a really big international reputation, and a lot of research was being done to prove the effectiveness of what we were doing in terms of people's health. Okay, what we knew and what we found then and from later research is that the rate of HIV transmission amongst drug users in the UK, in the Northwest and in the UK, remained really low, when other places that didn't have these harm reduction strategies actually suffered a lot and had a lot of HIV amongst their population. The problem with that is now, when we come into 2020, is that people that we started prescribing to in the 1990s who were maybe age 20, maybe still and are still using drugs some 30 years later on, some prescribed drugs and often drugs on top of their prescription as well. So we have an older population of drug users that we never really anticipated having, because the epidemic started, a heroin epidemic as it was called, back in the 1980s and 90s. So we've got a really big cohort of or population of older drug users who have been using drugs for many years. Just come and bang up to date and let me tell you a bit about drugs and the statistics around drugs, and the reason why I'm so interested as an adult nurse, looking after people, adults rather than children or people with mental health problems, is that around about 5.5% of the world's population, that's about 271 million people, have reported using an illicit substance in the last year. Now, if you think about those statistics, that that we can multiply that by an X factor. I don't know what factor, because it's really difficult to get accurate statistics, but they're people who have self-reported. Over 500,000 people a year die from drug-related problems or injection injuries, infections, and chronic conditions, and that's a real problem for us. Across Europe, we've developed the long-term prescribing program, so people are still prescribed long-term methadone. And in Europe, there's probably about 1.3 million people who are injecting substances regularly, only half of which are in contact with healthcare services. So we still have a massive problem across Europe and across the UK in terms of people's substance misuse. What we do know is the age of people using injection heroin is increasing. So they're getting older, which you would expect when they started taking drugs in the 90s, 80s, 90s, and further on. What we would do now in terms of predicting the future is that those people who are still using substances will actually add a load of cost to the healthcare services, because they're very difficult people to deal with when they've got maybe a mental health problem, a physical health problem, and family-related problems, and a substance misuse problem as well. That they're very difficult to help in terms of services. And we've got no precedent of this, because this is a brand new group of people who are using drugs for a long periods of time. So we're expected to see increase in hospitalizations, many more overdoses, and lots more infections, be that bloodborne viruses like hepatitis B and C or HIV. We also seeing now degenerative diseases coming earlier in than we would expect in this population when compared to people who don't use drugs. And then there's lots of problems being noted about long-term drug users developing cardiovascular problems like hypertension, angina, circulation problems because of their injection and the problems they've had with the circulation. And leg ulcers, which are really common in much older people in the UK, are increasingly becoming common amongst drug users who are aging. Lung infections like pneumonia, breathlessness, and a big disease called COPD, chronic obstructive pulmonary disease, are increasingly more common at an earlier age in this group of people. And there's been noted to be an increase in cancers that are related to their substance misuse. Now, the problem when we think about all of this is we can never actually be sure what's cause and effect here. That most drug users will come from a poor socioeconomic background and use substances and face other forms of deprivation, which may contribute to their long-term conditions. So what we do know is that they have very complex needs, not least of which there are major mental health problems of depression, anxiety, and increased suicide amongst this group of people. Okay. One of the things that we've noticed, Professor Paul Kingston, myself, and a senior lecturer called Vicky Whaley have just put a bid in to look at how we can make services better for drug users who've got long-term problems, and we're trying to investigate some of the reasons or some of the ways that we can intervene to solve this problem. So going back 30 years, we were identifying drug users, we were keeping them safe, we were trying to stop them catching HIV and other bloodborne viruses. Now, sometime later on, we're actually looking at the consequence of that successful strategy that is trying to keep people safe again or treat them early on. So what do we know? Or what's the so what of all of this? We've got an increasing growing number of older drug users who've got complex healthcare needs. They're developing long-term conditions sooner than they would otherwise, compared to other people who don't use substances. Drug treatment services don't really understand about their physical healthcare needs, because that's the way we've designed services in the past. And now we have a situation where primary healthcare services don't really understand their drug use and problems. So we've got a real problem there of the services being separate. So what does all of this mean for us? We know that nurses are very well placed to provide primary healthcare services, secondary healthcare services for people who have got chronic and ongoing healthcare problems, and they do that really successfully. We have a group of nurses now who are prescribers, who run their own clinics, who will only refer on to a medical doctor should the patient's condition deteriorate or should be something out with their experience, and then they'll pass that on to other people. But mostly, nurses are very well able to manage all of these healthcare problems and their substance misuse problems as well. Nurses can do assessments, can send people for tests, and can do a whole range of stuff. What we do need as well is we need more research, so that we need to understand what are the barriers to drug users and their family accessing primary healthcare services, what they need to do, what we need to do in order to make those services more accessible to people. And again, the work that Paul Kingston, Vicky Whaley and myself wanting to do in the near future is looking at how we can actually research that and make those services more applicable. What training needs are there for healthcare services? Okay. So to summarise just this bit before I tell you a little bit about studying nursing at Chester, it's really important to know that, I mean, if you look at my experience, and I'm not here just to sell myself, it's just, I started off with a very hospital-oriented career. I was working in A&E and ITU, which are absolutely essential, particularly now in the days of COVID, where we need more people who are able to work with people who are really sick. I changed direction after studying and thinking about public health, which is part of my degree. And I moved into the community. So it's not only about helping individuals like I did do when I was in hospital. Nurses also work in with the public health framework and work with individuals in the community and ultimately manage and protect public health. And this is what we did on Merseyside, Cheshire and on the Wirral. Just a little bit about nursing at Chester. I've only come here since September last year, and it's a great place to work. We've got a new Vice Chancellor, Professor Simmons, who's very, very committed to something called WP, which is close to my own heart. I was the first in my family to go to university, and it was a hard thing to do because most of my brothers went off and did manual jobs. We've got a really good dean of school who's very supportive. It's very difficult times at the moment in terms of students not being able to come into university, and we've got plans in place to support all our learning and make sure that the experience will be the best that we can make it. Our head of department, Jean Evers, Dr. Evers, is also ensuring that we can manage to provide a really good, sound educational experience. And Julie Bailey-McHale, who's the Associate Dean for Education, really, really important in terms of making sure that we can meet the new challenges of COVID. So Chester's a great place to work. It's a great place to study. And you'll get a lot of useful experience when you come to Chester. And what I wanted to do today is in the days when we're thinking about people being really, really sick in hospital for COVID, that there are other aspects to public health. And you'll see all of the public health experts on the television now that you will cover also as part of your training and your study here at the University of Chester, sorry. Okay. So there's just one question, if anybody else has got a question that they'd like to ask. Are the medical personnel who are complicit in drug problems in the UK? That's a really, really important question. Very many years ago, in Chester and where I worked in Manchester and on the Wirral, a lot of people were very anti us prescribing long-term methadone to people, and still people think that was a public health or it is a public health problem. But when you balance that against the fact that you look at other countries that didn't have the same approach, and their rates of HIV and communicable diseases like hepatitis B and C amongst drug users are much higher, and they've lost many more people. So a bit like they do now with the public health measures in the UK with COVID, and when is it safe to go out, when is it safe to lift restrictions, I think those same arguments were happening back in the 90s when people were saying, if we do this, it will protect that group of people and will protect the greater health, the public health of society as well. So that's me at about 20 minutes or so. Has anybody else here got any questions? Anybody that would like to ask anything? I think the most important thing I'd like to get across to you is that it's really not easy. It's not, my job is never easy. Nobody's job as a nurse is ever easy, but you need to think, people need to think about not just hospital nursing, that we can make a real big difference in primary health care in terms of the health of individuals, the health of communities, and ultimately, the health of the public, the wider public here and across the world. And that's, a really important take-home message. And I hope that in my explanation of what I did and the jobs that I've had in healthcare for the last 30 odd years, I've helped you see that, that there are things that we can do that are not all just about hospital-based treatments. Yeah, even though they're absolutely essential. Okay, Melanie, thank you for a very interesting and informative talk. Thank you for an interesting talk. Thanks, Ruben. So are any of you thinking of doing nursing or healthcare? Absolutely, Laurie, there's no way that you would not come across substance misusers or problem drinkers, and quite often people who have got mental health problems and a substance misuse problem and a lot of social problems and physical health problems as well. How do you think prevention education is standing up in the UK at the moment? That's a very, very tricky one, given where we are with the COVID situation. I think, to give the politicians' answer, we'll need to have a detailed look at what happened. And I think the question that Tundi asked before is really, really interesting, because that debate still goes on. There are many people who are anti-drugs who said that we've done nothing but make people depend for longer. And the people who are very concerned with public health who are saying, yeah, but look what happened in other countries where we didn't do this. So, and the research and the evidence and sometimes the arguments are quite fraught between people. But certainly, Laurie, you wouldn't escape dealing with people who use drugs or take alcohol as well. Hanneke, how do you think prevention and education is standing in the UK? I think I've just given a politician's answer on that one. We need to see the reviews. I think it took us all by surprise, the speed at which COVID-19 spread. Any more questions? No. My email address, if you want to ask me anything or want to, is so it's s.speed@chester.ac.uk. Okay, thank you very much for your attention. Thank you, Hanneke. It's really lovely feedback. It's really hard when you're speaking into a computer and you can't see, and you're used to teaching face to face. I was just talking to Alex about it before, the guy who set up the system. When you're used to teaching people and you get visual cues of how things are going down. Okay, so thank you very much for your attention. Okay, I'm going to end the stream now. There's my email address, should anybody be interested in this, I can forward you on, or healthcare or health studies, and I can forward you on to other people. Okay. Thank you very much for your attention, folks.